Hello, good evening and namaskar. It's a great pleasure to welcome you all for this excitement for this exciting webinar on lung cancer connect. It's a pleasure to welcome Dr. Amol Dongre sir. He is a senior consultant medical oncology at Alexis Multi-Specialty Hospital, along with the co-organizing secretary Dr. Nikhil Pande, consultant medical oncologist at SCG NSHRI Cancer Center, Nagpur. Without missing but words, I will give the floor to Dr. Amol Dongre, sir. Dr. Amol, sir, good evening to you. Thank you so much for joining, and we look forward for your welcome into an introduction and setting a context for today's discussion. So over to you,
Thank you.
Dr. Amol, sir.
Yeah, thank you very much, Tarun. A very warm good evening to everyone. So it gives us great pleasure, both me and Dr. Nikhil Pande, to welcome you all to this Lung Cancer Connect, which has been scheduled from today and tomorrow. So after a very successful conference last year, lung cancer, we agreed that a regular scientific and educational meeting in this area is important for providing a comprehensive overview of the most significant advances in lung cancer research and treatment. And we also know that over the past few years, molecular biology has revolutionized everything we have ever known about the natural history of this illness. And I believe everyone do agree with this. So treatment must be approached by multiple specialists and the strategy must be tailored for every patient. And that's the reason, we happen to take this meeting, Lung Cancer Connect. So this program also highlights the role of radiation in lung cancer treatment, especially in a oligometastatic disease. Okay, as well as the formidable development of new techniques such as SBRT, image guided, and IMRT. This conference is also going to feature presentation on optimizing the application of established targeted agents, as well as presentations introducing emerging targeted agents, including mechanism of action and the clinical results. So this program, like as I've already said, that we want to include all the specialities in this, and that's why we've divided day one into three sessions. Session one will be on the optimal management of oligometastatic disease. Session two will be on the precision diagnostics, and session three will be on management of EGFR mutant non-small cell lung cancer. So without wasting any time, I would like to call upon my first speaker, Dr. Vikas Talreja, who is a senior consultant medical oncologist at Department of Medical Oncology, Regency Hospital, Kanpur, and he'll be talking about the definition, basically medical oncology perspective as far as oligometastatic disease is concerned. So over to Dr. Vikas.
Perfect. I hope I'm audible right now and my screen is visible. And thank you for Dr. Amol sir and Dr. Nikhil Pande for a beautiful conference agenda. I am really looking forward for it. And definitely, lung cancer has seen so much advances right now that probably even the diabetes and hypertension wouldn't have seen over the past decade. And it has revolutionized as how we treat this disease. And that's why, without wasting further time, I would straight away jump, because since I am the opening batsman here, we need to define oligometastatic disease. Oligometastatic disease per se has a very important perspective. It has changed its designation for since a long time. Oligometastatic used to be a restricted tumor metastatic capacity, curative in proportion with the metastasis, and the practice has changed from two phase clinical trials where oligometastatic patients were treated with a local radical treatment as compared to palliative treatment, and both of these treatment showed that even though in a small subset of patients there is a definitively different way we should be managing it. And when we hit on the lung cancer oligometastatic disease, we see it is a very hot topic right now. So look at the number of the permit hits since 2010 to 2020. You see more and more people are.
So sorry for intervening. Your slides are not moving, sir.
Okay, I will share it again. Yes. So again, as we know that the local consolidative therapy always improves the overall survival, and that's why the standard of care in oligometastatic lung cancer is now shifting from just a systemic care to a local care also along with the systemic care. And when we look at the retrospective records for it, there is a randomized trial. Everybody knows it by the Saber Comet trial. Next slide, please, where the benefit of adding a local consolidative therapy to the chemotherapy arm also has a very important uh, uh, implications in terms of the overall survival for it. The next slide, please. That's the local consolidative therapy versus the maintenance versus the observation for patients with an oligometastatic non-small cell lung cancer without progression after a first line systemic therapy. So definitely systemic therapy forms the altogether basis for it. But what more we can do apart from the systemic therapy is those uh, local therapies which we discuss for. The next we will discuss about the Gomez trial design. Next slide, please, where less than three non-progressing lesions the local consolidative therapy, and based on the responses and the tolerance of these, it was, next slide please, they were in the Saber Comet, it was the 5 metastatic lesions, and both of these have shown that the addition of the local consolidative therapy always have a upper limit for it. And there is a future trial where there is no upper limit for the metastasis, and I believe we have a whole game that is being changed. So next slide, please. So when we look at this, we need to see that a uniform definition is definitely needed. We have to define oligometastatic. Oligo means a few, a little, a too little, but again, a definition has to be provided for these. And that's where there has been numerous surveys also where when we discuss next slides. Next, 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 next. So in these surveys, when we discuss what was the aim, so 80% of the respondents who were oncologists, who were the treating physicians, wanted a cure out of the oligometastatic situations. And the number of the organs has been, it depends upon, you can see all range from 1 to 5 to more than 5. There is no issues when the radical treatment is possible, and that's where this is important. And that's where instead of being a case-based report, it should be a multidisciplinary expert opinion. Next slide. To next slide, please. You could see that addition of what the basic biology is. So try to understand in this subset, when there was oligometastatic in brain as compared to oligometastatic in lungs, as compared to oligometastatic in renal and adrenal, all have a 5-year overall survival in addition to the systemic treatment we give. So the systemic treatment is the main treatment that we have to do, and we have to go up, over and above, and provide a more than the systemic treatment for that oligoprogression disease. So definitely there was, next slide please, next slide please. Oligometastatic around a systemic review was done where 1215 patients were taken, and out of those the more than 3 metastases were included to have that uniform definition for it, and then a consensus statement was made, and that was the published in JTO. Next. So when a radical treatment is technically feasible with acceptable toxicities taking into account all sites that modify the course of the disease leading to a long-term disease control, that's where the oligometastatic is there. And based on that review, maximum 5 metastases in 3 organs proposed. Diffuse serous cell mets, diffuse bone marrow mets totally excluded. Mediastinal lymph node is considered local disease but should be taken into account in determining whether the radical treatment is possible. Next slide, please. And for them, definitive mandatory mediastinal staging and PET CT and a brain imaging is recommended before we label it as an oligometastatic diseases as compared to the conventional practices in there. And Next slide, please. And when they published it, they said based on the Gomez design, less than 3 non-progressing lesions, they were randomized, or less than or equal to 6 sites of disease at the time of the randomization. The oligometastatic was there. Now, there is a different school of thought for a genuine oligometastatic disease, and there is an induced oligometastatic disease. So again, they were randomized based on the de novo oligometastatic or the repeat oligometastatic disease, and they were again classified based on the synchronous and the metachronous, and then again metachronous oligo recurrence and metachronous oligo progression. So we next slide. We have a different dimensions to it. We have a different treatment to it, and the trial was definitely close prematurity when the local consolidative therapy had a significant benefit. And similarly, the Gomez results also had a significant benefit over and above the therapy with the significant p values. And next slide, we go to the Syndas trial. Next. Again, the SBRT, in addition to the TKIs, also to the oligometastatic disease, had a significant PFS and OS benefit as compared to it. Besides the number of the metastasis, the number and the type of the organs with metastasis involved, and also the number of the prognostic significance of the total tumor volume that needs to be determined. And ideally, ongoing registries trials should collect prospective data on these topics, and also the oncogene addicted versus the non-oncogene addicted population. So next, we have to have a standard definitions for it, standard recruitment, because there is a lot of contamination of the patients who seek SRS, SABR outside of the clinical trial while on there, and that's where we tend to get the diluted results for it. So again, to reinforce, I would like to conclude that medical oncology is a mainstay treatment for it. The local consolidative measures, either it is SRS, SBRT, or the local measures add on to the therapies, and we should be doing it for a radical intent cure patients for oligo progression. Thank you, and would love to answer any questions if there are any.
Yeah, so thank you very much, Dr. Vikas. As rightly said, that medical oncology is an important role to play in that in oligometastatic disease, but definitely after your talk is Dr. Chandni's talk, and I'm sure she'll have more to say about the role of radiation in oligometastatic disease. But just one question from my side, Vikas. So how often you see a oligometastatic disease? Like, previously oligometastatic disease is confined to, mostly colon. And now, like, often we seen different other type of cancers regarding oligometastatic, and we tend to treat them with curative intent. So what's your basically experience of oligometastatic disease in lung per se?
Per se in lung, I have seen, so I believe every day we are learning, and we see a lot and lots of patients where only one site of progression is there, and then to label them as a metastatic, frankly, it would be something we don't tend to do it, because we have been they have been close to our heart as a curative intent throughout. So and then I believe these oligosite treatments are very important, because now many trials have shown the addition of the local consolidative therapy as having a beneficial effect to it. And if I see in oncogene addicted patients, I believe 30-40% of these patients do tend to develop an oligo progression either in brain or in lungs, or some ground glass obesities, some oligo liver mets, some adrenal mets, and there the local consolidative therapy do have a very important implications.
Perfect, Vikas. So thank you very much, Dr. Vikas, for such a lucid presentation. Now we'll move on to our next presentation, that is by Dr. Chandni Hotwani, madam. She is a senior consultant radiation oncologist at Alexis Multispeciality Hospital, Nagpur. And let us hear from her about the optimal management of oligometastatic disease as far as radiation oncology perspective. Over to Dr. Chandni, ma'am.
Good evening, everyone, and thank you, Amol, for giving me this opportunity. I hope the slides are visible and I'm audible too.
Perfect, ma'am. Perfect.
Thank you. So next slide, please. So today we'll be, I'll try to cover up the topics in terms of, next please. Keep on clicking. So first we'll understand what the oligometastasis basically means and the concept of SBRT and SRS in such cases. So next slide, please. So as we all know, the spectrum of any malignant disease is basically either local or local regional and extending up to the disseminated disease. Whereas lately, next slide, please. So as early as 1995, when the concept of oligometastasis was given, wherein oligometastasis basically being an intermediate stage between locoregional disease versus disseminated disease, and such patients can be amenable to a curative therapeutic. The metastatic sites and metachronous oligomets, wherein the primary again remains uncontrolled with the interval being more than 2 months to spread to other sites, and oligorecurrence and oligoprogression are seen when the primary is initially treated and the recurrence can be seen at a limit with no systemic therapy ongoing oligorecurrence and oligoprogression. Few mets are seen in progression while the patient is on systemic therapy. So basically, oligoprogression is nowadays commonly seen for patients who are EGFR or ALK positive and have been treated initially with TKIs, and later there is progression at limited number of sites. So these are the patients again who can be considered for aggressive local treatment. So difference in definition has been always there. So oligometastasis many of the times is considered as up to 5 lesions involving 3 different organs, which was the final consensus given by the EORTC at this HISTRO meeting. And generally there has been seen that the prognosis for 1 to 3 lesions is much favorable than those patients having 4 to 5 metastatic lesions. Next slide, please. Next slide, please. Commonly in lung cancer, the patterns of failure have been seen in bones, lung, liver, and adrenal. So bone metastases are more common in patients with central tumors, whereas contralateral lung mets are seen in those with peripheral tumors. And so coming to basically management of oligometastatic disease, the scenario is very commonly seen these days because of more aggressive use of PET-CT and MRI brain. So the patients are very commonly seen with limited spread of disease, and almost 15% patients may be upstaged from stage 2 to 3 at presentation to stage 4 by the use of PET-CT. And these days, as the techniques are available to ablate the local metastatic sites, it is still hopeful nowadays to treat these patients with curative intent. Also, the incidence of other slides visible?
No. Kindly share your screen, Dr. Chandni.
I was not sharing actually up on this.
Technical team, what happened? Technical.
So you just have to say next slide.
Yeah, so coming to the question of why the local ablative treatment. So there have been studies which have proven that commonly the recurrence in such oligometastatic stage has been in local site only after systemic therapy to as high as 60%. And there has been evidence which says that aggressive local treatment leads to improvement in both progression-free survival as well as overall survival. There was a study by Johnson et al. Where he reported a 5-year overall survival rate of 58% in 22 patients who presented with synchronous oligometastatic non-small cell cancer, wherein the mediastinal node involvement was not seen and who had undergone surgery or radiation to the primary site as well as the metastatic sites. Yes. Also, the 8th edition of TNM has also considered the benefit of aggressive local treatment. That's why they have classified the M stage into 1A, 1B, and 1C, wherein M1A is contralateral solitary lung nodule, where the survival ranges to as high as 22.5 months if treated aggressively, and 1B is solitary extrathoracic site disease up to 1 to 2 sites involved, the OS remaining 17.8 months. And in M1C, where multiple extrathoracic disease sites can be seen, around 3 to 4 sites treated again aggressively with a median OS of 13.6 months. So there has been one more hypothesis which favors the local treatment to improve the outcomes, where we have seen that the effect of systemic therapy is proportional to the rate of tumor growth, and the tumor growth otherwise follows a sigmoidal pattern. So when we give local ablative therapy, it can bring back the growth curve to exponential growth, and hence there is a possibility of eliminating an evolutionary reservoir of resistant subclones, thus benefiting the patients by combining local and systemic therapy to improve the overall survival. Next one. Now, as previously talked about by Dr. Vikas also, this randomized trial by Gomez et al., wherein there was a comparison between maintenance versus local ablative therapy for oligometastatic patients, which showed a significant improvement in progression-free survival in patients who were treated for local disease, with a median PFS time of 11.9 months versus 3.9 months, and 1 year PFS rate of 48 versus 20%. And the patterns of failure of new versus known was also seen favoring the local consolidative arm. And the time these are the graphs showing the PFS and survival which both favored the local consolidative arm, and the p-value was also significant. Next slide. So in this table, we can see that when the treatment of maintenance versus local ablation was compared, there was a benefit in PFS of the p-significant value of 0.005. And so this was one first randomized trial showing the benefit of local consolidative therapy in such patients. Next slide. Next slide, please. And this is a table showing multiple trials who have studied the benefit of local consolidative therapy in oligometastatic disease. And everyone, all of these trials have shown a local control and PFS with OS benefit with combination of local ablative therapy in the form of surgery or radiotherapy. Next slide, please. This was another latest trial, which was Saber Comet, wherein multiple sites of primary like lung, breast, prostate were taken. And the lung patients with oligomets were 18 in this trial. And the comparison was between standard of care, which was palliative, versus standard of care plus SBRT. The median follow-up being 51 months, and the endpoint being 5-year overall survival, which was very significantly improved with local ablative therapy to as high as 42.3%. And the other toxicity and quality of life also showed benefit. Next slide, please. So these are again the graphs of survival showing a median OS of 50 months for patients who were treated locally and median PFS of 11.6 months, all the p-values being significant here. Next slide. So which patients basically do we treat with ablative treatment? Because as we all know, even among the oligometastatic patients, only 15 to 25% really have a benefit in DFI after aggressive local ablative therapy. So if there is only single extrathoracic metastasis, the DFI can be 8.7 months median. And if there are multiple mets in single organ, the DFI may be slightly lower as of 6.2 months. Whereas if there are multiple mets in multiple organs, it can further lower down to a median DFI of 5.1 months. So we need to very carefully select these patients. There are multiple factors suggesting the prognostic outcomes, wherein the number of mets, as we all have said, even among the 5, up to 2 or 3 mets, the patients do favorably. And if the DFI between the primary treatment and the appearance of metastasis is more than 6 months, if there is no mediastinal nodal involvement with the histology of adenocarcinoma, the patients with the younger age with good PS, and for brain mets specifically, we follow a GPS score, which I'll be talking further. The sites of brain, that is brain and adrenal mets do favor as compared to liver and bone, and pathological T staging at the time of primary treatment. Also, the molecular form profile with EGFR and ALK positive patients doing favorably as compared to negative. This Ashworth classification was also suggested, wherein the author has talked about the appearance of metastasis. So the patients who present with metachronous metastasis are considered as low risk, with the 5-year overall survival being 47.8%. Intermediate risk patients are those with synchronous metastasis but N0 disease, having a 5-year overall survival of 36.2%. And the high risk patients are those with synchronous mets and N1 or N2 disease, wherein the 5-year OS can be as low as 13.8%.
Ma'am, can you just conclude your discussion, please?
Okay, yeah, I'll be moving faster. So we can go to the next slide. So coming to the modalities of local ablative therapy, surgery has been commonly used, but it is not possible for all patients to undergo surgery because of age, comorbidities, location of the tumor being difficult to assess, and if the recovery is prolonged, it may be unacceptably delaying the initiation of systemic therapy. Next slide, please. Also, RFA in NSCLC for oligomets has not been very well studied, so it is not very commonly used. Next slide, please. Next. So coming to SBRT, it is very commonly used nowadays because of the availability of technology and the toxicity being very acceptable. Next slide, please. Next slide. So brain mets being the very common presentation for NSCLC, SRS has been now the standard of care, wherein single to up to 3 sessions can be delivered with very acceptable toxicity and a local control of as high as 80 to 90%. Next slide, please. This is the GPS score. So if the patient has score of around 1.5 to 3 or 4, the patients are very favorably responding, whereas 0 to 1 can be very poor score for the outcomes. Next slide, please. Next slide. Next slide. Next slide. Next. So for intrathoracic mets, wherein the contralateral lung lesions can also be treated with SBRT. Next slide, please. However, we need to compare if it is second primary or a metastatic disease, and there have been better overall survival if the node negative disease is treated with SBRT. And the dose of SBRT for lung lesions, if it is centrally located, can be about 5 to 6 days in 6 sessions, and for peripherally, it can be around 11 to 15 days for 4 to 5 sessions. Next one. So adrenal also are very common in lung patients. Next slide. Next. Bone mets and liver mets, as I have already said, they have very poor outcomes in patients with NSCLC. However, if there are only
Chani, we can't hear you. We can't hear you properly, Chani.
Okay. Yeah. So for bone mets, the SBRT can be delivered to. Abhi, I'm audible?
Yeah.
So bone mets and liver mets are very poor prognostic as per NSCLC is concerned. However, if the patient presents with limited bone or liver disease, SBRT can be delivered for bone mets to a dose of 27 to 30 gray in 3 fractions. And liver mets can be treated again as per the location. So for peripheral liver lesions, we can give up to 20 gray into 3 fractions. And for centrally located within 2 centimeter of porta hepatis, we need to divide the dose up to 5 fractions. Next slide, please. Next. Now coming to sequence of treatment. So for synchronous oligometastatic, first systemic therapy needs to be given so as to see the response evaluation, and then ablative treatment can be done for the responders. Whereas if there are only brain mets, upfront surgery or SRS should be done followed by systemic therapy. And for oligoprogressive, local ablative treatment can be done followed by maintenance chemotherapy or TKI. The systemic maintenance therapy can be given in switch maintenance. Benefit with allottinib in Saturn trial. Next slide, please. oligometastasis. Because next slide, please. So this is the basically diagnosis. Studies where they have shown that pembrolizumab, if given within 7 days after SBRT, there has been improvement in the outcomes. And in the Pembro-RT study also, where only one metastatic lesion was treated with 3 fractions of SBRT before the start of immune checkpoint inhibitors. And in MD Anderson trial, up to 4 lesions were treated with SBRT followed by the first dose of ICI.
Ma'am, my apologies, but should be a last slide, ma'am, because we are running short of time. A very
So
humble
I'll
request,
just come
ma'am.
to the
Please come,
summary.
please
I'll
come
just
to the
come to the
conclusion, ma'am.
summary.
Come to the
Yeah.
conclusion, ma'am. Yes, very sorry for this.
That's okay. So to thank you. And sorry for the long presentation.
Yeah. No, thanks a lot. Thank you, Dr. Chandni, for this excellent presentation about the radiation oncology perspective. So we know, there's lot more in radiation as far as oligometastatic disease is concerned, and definitely, I would like to ask you questions, but after Dr. Parag's talk, because then we need to know a surgical perspective also, because as of now, whenever we see oligometastatic disease, we tend to keep aside surgery and basically concentrate on systemic therapy and local therapy in the form of radiation mostly. So we'd like to be I would like you to be online, so that after Parag's talk we can again have question answer session. So my next speaker is Dr. Parag Ingle. He's a consultant surgical oncologist at HCG Cancer Hospital in Nagpur. And Dr. Parag will talk about the about surgical oncology perspective of oligometastatic disease. So over to Dr. Parag. Yeah, Parag, you can start.
Organizing team and everybody else to include me in this webinar on oligometastatic disease. This highlights our thinking that even a surgical oncologist's opinion in management of a metastatic disease is important, and I appreciate this a lot. Thank you. So coming to definition, comparatively early metastasized tumor stage with a limited number of separate distinct organ metastases, as opposed to a diffuse
Parag,
metastasis.
can you make it slideshow? Can you make it slideshow? Your screen, just make it slideshow now.
Are the slides visible? I am sharing the screen.
Yeah, but you make it slideshow.
Okay. So a recent article from European Respiratory Review said that oligometastatic disease is comparatively early metastasized tumor stage with a limited number of separate distinct organ metastases, as opposed to a diffuse metastasized disease. The definition is not consistent, and up to 5 isolated metastases have been included in various trials which have been published. So there is a discrepancy in the definition. The discrepancy is pertaining to following points like presentation. It can be synchronous or metachronous. The number of metastases, up to 5 have been included in some definitions. and site of appearance. It could be in one organ or multiple organs, usually up to 3 organs. So this is what the regarding the part of definition for oligometastatic disease. Now coming to surgery as a part of multimodality approach to treatment of oligometastatic disease. So surgery has become increasingly relevant in this oligometastatic disease scenario, because with advances in immunotherapy and targeted therapies, there has been an increase in survival of the patients. And by sequencing surgery into the whole treatment sequence, definitely we can offer a better survival to these oligometastatic disease patients. So in this presentation, I would discuss briefly about role of surgery in limited metastasis disease. And for that, I am describing the results of 3 studies published related to outcomes for surgical procedures for limited metastatic disease for lung cancer. So this is one published in 2014, and they have studied 34 eligible patients for whom complete resection of primary lung cancer and metastasis has been done. And out of total 36 patients, they analyzed 34 patients in whom 20 patients underwent surgical resection of primary as well as of the metastasis. And they found that patients undergoing complete resection of both primary tumor and metastasis had a 5-year survival of 44.7%. And I would say that is a decent survival. Disease lung cancer patients. So they had concluded that clinical T1, T2, N0 or N1 lung cancer with single organ metastatic lesion were a good candidate for surgical resection, and a 5-year survival rate of about 40% can be expected. So this study was published in 2014. Now coming to the role of N2 mediastinal nodal stations. So there was a comment on N2 mediastinal nodes in oligometastatic disease, and N2 disease with single organ metastasis should be classified as a systemic disease rather than an oligometastatic disease is the comment in their discussion. And many studies agree to this comment, and patients with N2 positive oligometastatic disease their clinical outcomes are really not good. So another study which has been highly cited but a little older one is by Pande in lung cancer 2010, and they found that 5-year survival of around 11 to 30% is seen in patients with resected oligometastasis with brain mets, and about 26% in patients who underwent adrenalectomy for adrenal mets from lung cancer. Now coming to a recent study published in 2020, they studied 57 patients oligometastatic stage 4 lung cancer who had 1 or 2 oligomets, underwent multidisciplinary approach including surgery. Majority of their patients underwent induction chemotherapy. 81 patients had local treatment of the distant metastasis before lung resection. And patients with bulky N2 involvement or multiple N2 stations or progression in mediastinal lymph nodes, that is N2 locations, were excluded. And they found that a median OS of 30 months was seen, and OS was significantly related to lymph node involvement. So these graphs show us that it is significantly related. The survival is better in patients who had N0 nodal status and a smaller tumor size. It was also seen to be related to the size of primary tumor, neoadjuvant therapy, and the time period between metastasis diagnosis and primary tumor removal. So they concluded that acceptable OS in a multidisciplinary setting is feasible, is possible. No lymph node involvement patients are best candidates to offer surgery. The overall survival rate was not significantly related to the number of distant mets, but it was related to the lymph node involvement and dimension of the tumor. So patients with no lymph node involvement are best candidates and have an acceptable overall survival rate. So this is a fairly recent study which shows that surgery, especially in oligometastatic lung cancer without mediastinal lymph nodes, without N2 positive lymph nodes, do have a good survival. And coming to NCCN guidelines also include surgery as a part of the multimodal treatment for oligometastatic disease, especially fairly commonly seen oligometastatic diseases with brain mets. And for limited metastasis with brain mets, they include surgical resection of the brain met as well as of the primary in the treatment sequence. And for treatment of the primary lung tumor, for N2 stations, they do not consider surgery, but for rest of N0 or N1, the surgical resection is considered. Now coming to the meta-analysis by Ashworth, which has been the basis for NCCN recommendations. In very briefly, I would like to tell you that it was individual patient meta-analysis of 757 patients with 1 to 5 synchronous or metachronous metastasis. Surgery was the most commonly used treatment for primary tumor as well as metastasis. And factors predictive of overall survival were synchronous versus metachronous metastasis. In the sense, metachronous metastasis did well. End stage, N2 did poorly, and adenocarcinoma histology. And they tried to risk stratify the patients. So low risk patients were those with metachronous metastasis, had a good 5-year OS. Intermediate risk were synchronous mets and N0 disease. And patients with synchronous mets and N1 or N2 disease had a poor overall survival. So I think these 3 studies and Ashworth meta-analysis clarify that surgery does have a role in oligometastatic disease when applied in a proper sequence, especially after induction chemotherapy and in patients who do not have a N2 disease. So proper staging after a PET CT, mediastinal staging with EBUS followed by mediastinoscopy to consider offering surgery is important. And one slide on what is evidence-based medicine. Just to revise, evidence-based medicine includes considering relevant scientific evidence, patient values and preferences, and clinical judgment. Relevance of putting this slide here is the relevant scientific evidence I feel for oligometastatic disease is still not very robust or not not much of evidence is available. So I think apart from that, we need to consider the disease biology. We should apply our clinical judgment of the multidisciplinary team, and we should also take into consideration patient preferences to offer a treatment for a patient with oligometastatic lung disease.
So great presentation. If you can just conclude, please.
Yeah.
Excellent.
So take home messages. Therapy for oligometastatic disease is evolving and we will keep on evolving because the number of patients are small. Selected patients do benefit from surgery. Multidisciplinary management is essential and it is important to rule out N2 disease before offering surgery. Thank you.
Excellent presentation, Parag. I really like your the second last slide about evidence-based medicine and this slide, relevant scientific evidence, clinical judgment, and patients' values and preference is what actually makes evidence-based medicine. And to again reiterate what you said, so there is Parag, you do agree that there is a role of surgery in oligometastatic disease?
Yeah, I agree.
Yeah, I agree. Back to Dr. Chandni. Just I'll take 2 minutes. Dr. Chandni, what's your say on the role of oligometastatic role of surgery vis-a-vis radiation in oligometastatic disease?
So, as I have also shown, evidence does exist for surgery also, but until looking at the age, comorbidities, PS, and if there is no unacceptable delay in initiating further therapy, if the location also allows, it should be done. It can be considered.
Right. So, yeah. So, thank you, Dr. Chandni and Dr. Parag. So, we'll move on to our next session, which is basically on precision diagnostics. And for this, I would like to call upon my first speaker. This is Dr. Anuradha Chowgule, madam. Madam is a professor and scientist in charge of the molecular laboratory, Tata Memorial Hospital, Mumbai. And madam will give talk on molecular diagnostics. Who, which, when, why, and how. So over to Dr. Anuradha Chowgule, madam.
Yeah, thank you, organizing committee. So now in this precision medicine, you all know that molecular diagnostics has become mandatory, and we need to really to know which patients, who, when, why, and how. So in this overview of this my talk, I'll be discussing about this. So I'm very happy to share that we started the EGFR testing in 2011, and in almost a decade, we have done around almost 10,000 testing of EGFR, and the data is under analysis and will be soon under publication. So as you all know, the most frequent EGFR TKI sensitizing mutations are exon 19 and 21, but the same story doesn't remain now, because apart from exon T790 mutation, exon 20 insertion and S768I are also very important part in the detecting at the baseline, because the partial the treatment is available as a first line, that is the osimertinib. So there are several stakeholders which are involved in the diagnosis and management of lung cancer. As you can see over here, primary care clinicians, pulmonologists, interventional radiologists, thoracic surgeons, pathologists, medical oncologists, and last but not the least, the molecular biologists and the basic scientists, because due to the paradigm shift from chemotherapy to the precision medicine.
Madam, we can't see your slides, ma'am.
I've asked to share the slides to Garima. Next, hello.
Technical
Garima?
team, please share madam's.
Garima? Okay, now
it's visible.
next slide. Sorry to mention that as the next slide, as usual. Okay, so next slide. Yeah, next slide, please. So there is a clear exchange of technically and clinically useful information is vital. Next slide. So who needs to be tested? Disease stage, only test patient with advanced stage 4 disease, age, or only test younger patients, only test adenocarcinomas, or only test non-smokers. Next slide, please. So as you can see one of the analysis of our 10,000 patients. You can see apart from adenocarcinoma and squamous cell carcinoma, you can see some of the EGFR mutations present in the large lung cell carcinoma as well, and the small cell carcinoma as well. So in this today's precision medicine, I think the small percentage of EGFR mutation positive makes very vital. Next slide, please. So again, all histologies need to be tested. As I said, apart from adenosquamous, so large cell and the small cell also need to be tested at EGFR for the EGFR testing, though the NCCN guidelines doesn't means right now. So it is a small case where the small study where they had done the pulmonary sarcomatoid carcinomas, and they found that there are 16 variants which are the hotspot mutations like EGFR, AML for ALK, MET, BRAF, PIK3C, and TP53. So the molecular targeted therapy may be useful treatment for this PSC with targetable alteration. Similarly, the MET exon 14, which is the most prevalent one, prevalence in the mutation, it was investigated with the NGS. They found that in the pulmonary sarcomatoid, EGFR, KRAS, ALK, ROS1, and RET were positive, and the patient could be treated with MET exon 14 skipping positive. Next slide. Yeah, again, coming with the whether now there is a trend of doing the EGFR testing in the early stage cancer in the stage 1 and 2. And as you can see over in the ADURA phase 3 trial, though it's an ongoing trial, you can see some of the EGFR were positive, so the percentage has not been given here, but they were benefited in the early stage cancer in the early stage 1 and 2. Next slide, please. So whether we should do the biomarker in young and old smokers? Yes, EGFR mutations, ALK rearrangement, ROS, and HER2 exon 20 insertions are more common in young patients, and frequency steadily decreases with the disease. Coming to the old patients, KRAS, BRAF, 600, MET exon 14 mutations appear more common in the older patients. For coming to the smokers, yes, we need to do the EGFR testing or the biomarker testing in the smoking as well, because the MET inhibitors are more CMET is positive, and since the MET inhibitors are available, they can be clinically benefited. Same thing goes with the non-small cell, as non-smokers. EGFR, ALK, RET, and ROS are the more common, but we need to do the testing for the BRAF and KRAS mutations as well. So it's a multidisciplinary approach. The pulmonologist has to take the appropriate volume and quality to be given to the histopathology. Pathologists need to see that it has been judiciously used for the sensitive molecular profiling techniques apart from the histopathology. And oncologists, they need to avoid the rebiopsy in the recurrence or recurrent testing, because now the liquid biopsy tests are becoming more popular. So which biomarkers need to be tested? As per the NCCN guidelines, all the histology, as I said, either it is adeno or squamous, need to do the EGFR testing. But the standard of molecular testing under adeno, we need to EGFR, ALK, ROS1, BRAF, PDL1 are the standard care of testing, molecular testing. In the progression, yes, we need to look for the EGFR T790 ST790 mutation, but if you are doing the molecular profiling, then the recommended testing, you can go with a larger panel as well to look for the MET, RET, up to NTRK, RAS, and TP53 gene. So which molecular alteration need to be investigated? As I already mentioned, why they need to be tested? Because there are various inhibitors are available today, and the emerging test which is coming up is for the KRAS G12C, where you today the treatments are available for it. So what is the algorithm? So EGFR mutated patients, they need to look for the activating mutation exon 19 or 21. But again, as I mentioned, exon 20 mutation, if it is positive, they did not go for the platinum, but they can go for the partial inhibitor, like the partial treatment responders, like for the osimertinib. If the patient is positive for the exon 20 this sensitizing mutation, very well they go for the first generation treatment. Again, if in the recurrence, if T790 mutation is positive, then they can go for the third generation, that is the osimertinib. And again, if it is negative, they should follow the chemotherapy algorithm. At the same time, nowadays, as per the NCCN guidelines, we, apart from these biomarkers, we need to do the PDL1 testing as well. If it is positive, they can be very well treated with the PD1 inhibitors, and again, if negative, they need to go for the conventional chemotherapy treatment. So how to test for the genomic alterations, whether it should be one at a time or versus NGS, DNA versus RNA or tumor, liquid, or both, or only at diagnosis or at disease progression also. So where should the clinicians send the samples for testing? The sample should be tested, should be sent for the testing to the accredited laboratory, whether they need to look for whether there is a successful ICWA participation as well. Assessment of tumor nuclei % is recommended. Macro dissection, if possible, is essential, and all samples possible, as we have seen, of the lung cancer should be tested. So there's molecular methodology is the choice of the lab. Sensitivity of detection is linked to the sample assessment, and how the reporting should be done. Patient and sample unequivocally should be identified. Percentage tumor, molecular technology, and sensitivity of analysis should be stated. Sample enrichment, I already mentioned, the tumor content should be minimum 10 to 30%. 10% is for the real time, 20% for the Sanger sequencing, and 30% minimum for the NGS testing. And the DNA extracted from tumor should be enriched for the EGFR mutation. So which molecular testing techniques are available, and which are the common prevalent one? As you can see over here, for the various biomarkers like EGFR, HER2, MET, BRAF, KRAS, ALK, up to KRAS, you can see the tissue allelic specific PCR sequencing. Tissue FISH and tissue IC is not advisable because they are very less sensitive and they are not useful. But and coming for the ROS1, MET, RED, PDL1 protein, and NTRK fusion, tissue FISH and tissue IC as the most prevalent one, we should go for this testing. What are the best practice for the molecular testing? make sure the test can detect gene fusions and other alteration in addition to mutations in terms of the NGS testing. And when to perform, all treatment naive patients should undergo genomic testing. New tissue biopsy and or plasma based test needs to occur when patients develop resistant or disease progression, and communicate with the colleagues who perform biopsies about the necessity of acquiring as much tissue as possible for DNA testing. So as you can see, the most of the tests are the FISH and IHC for the EGFR test, other than that, EGFR and IHC, but we should be more concentrating on the PCR and the sequencing testing.
Last 3 minutes remaining, ma'am.
Yeah,
last
yeah.
3 minutes.
Yeah, so a comprehensive, so a one-time testing or NGS, if we are, the patient is affordable, one should go for the NGS testing because in the lung cancer tissue is issue and it should be used judicially. I'll skip this slide. So what are the external, we should look for the external quality assurance is must see that the lab performs the equals participation. So what is the workflow in the NGS? So sample assessment, storage and processing in the molecular diagnostic department, what is the workflow? Ability, which are the actionable mutations, they have been placed in the tier 1 or tier 2. Some of the, they're the potential clinical significance. And tier 3, under tier 3 comes the variant of unknown significance. And again, tier 4, still the data is not mature, they can be benign or likely benign variant. So I'll skip this slide. So to offer the test for the patient, there should be an effective genotyping. The most reliable approaches involve either a panel-based assay tested on a high-quality tissue biopsy or ctDNA analysis. So which are the first one to be followed, or by the reflex test to tumor genotyping if the liquid biopsy is negative for a targetable driver actionable mutation. So as you can see, the data is evolving for the EGFR exon 20 insertion. For the treatment, various TKI inhibitors are being prevalent for the treatment of the exon 20 insertions. This is a timeline for the various inhibitors which has involved for the various driver actionable mutations like EGFR, RET, ROS, ALK, TREC, MK, MEK, HER2, FGFR, VEGFR, and c-KIT and PDGFR kit. So again, I will skip this slide. So as you can see, the TKI inhibitors have showed a tremendous response as compared to the chemotherapy treatment. So what is the role of testing for circulating cell-free DNA? As I said, if the tissue is not available or the patient is not willing to do the test, and for the disease monitoring, the liquid biopsy testing is very much beneficial. So who can achieve this? So this multidisciplinary approach, I said, so for the molecular profiling in lung cancer, multidisciplinary communication is needed to identify the patients who have actionable biomarkers early in the management algorithm, and through enhanced communication, key disciplines can align toward the common goal of improved patient outcomes. And why do we need to do the molecular diagnostics as in-house? Because, and what should clinicians know about the NGS testing? So as I said, these are the various advantages to do the in-house molecular NGS molecular testing, whether it is real-time sequencing or the NGS. What are the advantage of it? The efficient urgent care is taken, turnaround time can be maintained, accuracy of testing is there, we can quality of testing can be assured, there is a complete information, quality in control, cost of the test is in control, reduced cost, customized panel can be used, better medicine can be given to the patient, and can develop also new assays. This is my last slide. So what the clinicians need to understand from this? So they should understand where and why I'm ordering the test, which panel is available, have I specified the variants for the NGS assay selection, whether as the regarding the sample selection, FFP, blood, fresh frozen, any sample limitations, we need to give the priority. Coming to the bioinformatics and interpretation, any limitations for info analysis for sample, we need that it should be reported well in the test reports and NGS reports. Really, do I understand the content? there are various molecular tumor board meetings should be conducted, so that the clinicians also have an interaction with the scientists where they can understand the interpretation of the reports. And do I need to inform the patients about possible incidental finding outs? It is, do I understand the content? Yes, the patient communication is very well important. Thank you so much.
Thank you very much, madam. That was a super presentation, and your last slide was just the most useful. I can say that where, which, when, why, and how to communicate to the patient. It was really nice presentation, ma'am. Because of lack of time, we are moving on to our next presentation. It's by Dr. Ghanshyam Biswas, sir. He is a senior consultant medical oncologist and executive director at Sparsh Hospital, Bhubaneswar. And sir will be talking on why to wait for molecular results before initiating therapy. So over to Dr. Biswas, sir, please.
Yeah, good evening all. So that was a great talk by madam. And
thank you so much. Yeah.
Thank you.
Yeah.
So I will just continue from where she has left, and thanks organizers for this opportunity. So why to wait for molecular results before initiation? So why will wait for Dr. Anuradha to give the report? So probably all roads leads to NGS. So it's not like the Russia and the Ukraine war, the roads are moving away from there. So if you see in this COVID pandemic, only in 1 year, so May 2020 to May 2021, so there are 10 approvals, FDA approvals, only in the non-small cell lung cancer space. So that's how the power of a molecular or the precision oncology today. So this is, we are aware that once we have an advanced non-small cell lung cancer, so histology is important, and then so thereafter, so you try to do a molecular based profiling. So as madam said, so the cost is not a matter today, because if at all the patient cannot afford, so there are organizations, there are companies who are supporting to do a broad-based NGS. So at this moment, many of us have shifted from 5-gene panel to at least 12-gene panel, including a PDL1. If you see the NCCN, and if you see Dr. Anuradha's slides also, even in a squamous cell, even in a large cell, even in a small cell, so you can also find some of these molecular targets available. So once you have a PDL1 expression more than 50%, so you know what to do. But so if the PDL1 expression is more than 50%, but they should be negative for actionable molecular markers, and there should not be contraindications of PD1 and a PDL1 inhibitors, then your patients become a candidate for either a monotherapy with IO or in combinations. So this is a context setting of this talk. So these statements are by Julia, so from Dana-Farber. She says, in advanced NSCLC, the surge of targeted therapy options for patients who harbor actionable molecular alterations has shed light on the importance of waiting for the results of tissue-based or a blood-based whenever possible. So initiation of immunotherapy in patients who are eligible for targeted therapy can be significantly detrimental for their outcomes. So it is important to have all the data before starting treatment, so we know that we are starting with the most effective initial or the first line therapy, and thereby giving a space to sequence therapies. We know that there are drugs in the anti-GFR space, there are drugs in the anti-ALK space. So we always have the option to start a more generic initial treatment plan with a standard platinum-based chemotherapy doublets if these are not genomic alterations are found out. So advanced lung cancer without driver mutation, so that's probably the majority cohort. If you see the initial trials where Dr. Anuradha also touched upon, if you see those patients who aren't EGFR positive and has received those at that time the gefitinib and erlotinib, so response rates were inferior, disease control rate was inferior. So 68% versus 11% responses. So EGFR mutation versus EGFR negative, disease control rate 86 versus 42%. If you see the PFS 12 versus 3 months, median survival 24 versus 12 months. So the patients who are EGFR negative and you have exposed them to anti-EGFR drug without knowing that, so the probably you are doing more harm than benefit. So there is a recent article which shows that does the waiting period for genetic test affect the prognosis in chemotherapy treated de novo metastatic non-small cell patients without a driver mutation? The result was that it has shown a higher DDC. DDC stands for duration between diagnosis and the start of first-line chemotherapy, was not associated with the worse prognosis in a metastatic NSCLC without driver mutation. In this context, it is safer for patients and their physicians to wait for the test results before starting therapy. So this was less than 30 days versus more than 30 days in many tier 2 cities like ours. So the days, number of days, the NGS report from 28 days to 21 days, now we can get a report at 16, 17 days. If you see the graph on the left hand side, so those group A, so where less than 30 versus group B more than 30, so that neither the PFS nor the OS was different. So advanced lung cancer who are symptomatic. Now your patient is symptomatic, he is demanding treatment. So how do you approach this? So patients' probability of benefiting from chemotherapy with or without immunotherapy, probability of them having an actionable alterations depending on the clinical profile and the smoking status. And third, so what is the urgency of this situation to start on a therapy? So if you take the high probability of an actionable alteration, so these are young non-smokers, so probably they can harbor EGFR, ALK, ROS as compared to the older patients who have been a heavy smoker. In these patients, if forced to start therapy because the clinical situation warrants treatment immediately, so these are the patients where you have to defer the inclusion of a checkpoint inhibitor in cycle 1 and simply give a platinum doublet. So these days we know that so pemetrexed carboplatin is well tolerated, or a weekly taxanes and a platinum can be given. So this is certainly an off-label strategy, but it can offer a balance between starting treatment, taking care of the anxiety of the patient and the physician, and safely regarding timing of checkpoint inhibitor initiation later on. So somebody who has a moderate risk of harboring an actionable alteration, so wait, so you can send a liquid-based testing results. We know that you can get them within a week. If those results are negative, the probability of finding something actionable is low. If there is a strong clinical imperative to start on doublet therapy. It is always very important when consider dropping immunotherapy in the first cycle. So tell the patient that in the clinical trials, so all these patients has received immunotherapy on the first go. So where you can consider starting therapy. So these are actually a symptomatic patient, and actually these are a minority of the patients. So if they are symptomatic, so suppose somebody has come with a brain med, so by that time your molecular report come, so you can send the patient for a radiation. If somebody has a spinal cord compression, so you can give a radiation. Somebody has a bleeding, so you can go for a hemostatic RT. If symptomatic therapy is truly required, choose a combination of a platinum doublet. Avoid the introduction of immunotherapy till the NGS, the report is come. Make sure that the targeted therapy options are excluded at the time of adding immunotherapy. So advanced lung cancer with the driver mutations and a high PD-L1. So that's most important today. So numerous gene alterations are there. So with the targeted therapy, you know that we have a modest response rate, PFS, but the OS gain is not seen till we have come with the third generation anti-EGFR. So progression to TKI is inevitable, and most patients will at some point of time, they are going to progress. So genomic alteration in lung cancer is not restricted to metastatic lung cancer. So you can see that even in the early lung cancer, so there is lots of happening, and that's why probably the osimertinib has come into an adjuvant picture. So PD-L1 expression in lung cancer with driver mutation. You can see this graph. So somebody who has a high PD-L1, so they are likely to have a TP53, KRAS, MET, ATM, rather than EGFR on STK11. So when the PDL are usually low. So PD-L1 expression in lung cancer with driver mutations are not predictive. On the left hand side, response to immune checkpoint inhibitors not linked to PD-L1 expression, especially in EGFR, but that's not true in case of a KRAS. If you see the FLORA, osimertinib efficacy unaffected by the PD-L1. Even with the high PDL1, the response rate was 80% with a PFS of 18 months. And with the low PDL1, again, the response rate was more than 80% and a significant p-value of PFS of 18 months. So disappointing results in previously treated EGFR, if you see this red box, so be it a local trial, the checkmate, keynote, so all these have shown, so you can see the hazard ratio of more than 1. So all these patients in circulation in the body to modify the immune system for potentially or a prolonged period of time. So there is some tail effect. So we always tell that immunotherapy has a longer tail. So even in transition between an immune-based therapy and a target therapy, that sequence may hold elevated risk. So and that risk is present even if the drugs are not given simultaneously during treatment. So the checkpoint blockade, again a check for a targeted therapy. So if that's not there, then you have to go with chemotherapy or chemotherapy with an immune checkpoint inhibitors. It is a wrong way. So from the ASCO 20, so immune checkpoint inhibitor to start with following a targeted therapy we have seen. So neither the responses are there, but you land up in toxicity. You lose an EGFR mutant patients early because of a toxicity. So the lung cancer with driver mutations, so if you look at the targeted and immunogenicity on the left-hand side, so these TP53, KRAS, STK11, HER2 MET, so probably, so these are not the candidates for a targeted therapy even with the PDL1 high. Whereas EGFR or ALK or a ROS, so once they have these are altered with even with the high PDL1, so you are going to start your targeted therapy first. So the final takeaway, patients who have a diagnosis of lung cancers are eager to get started on therapy, and so as few of our physicians too. So diagnosis is not complete by the introduction of the histological part only. Treatment is much more guided by their molecular markers in 2022. So those who request, so there is no urgency in the sense that an additional few weeks for testing, because at least like Dr. Anuradha, so they are making efforts to get the NGS report within 2 weeks. So obviously it's an additional stressor for the patient, but the potential gain at the end is high if you have a dialogue between the patient, the doctor and the patient attendant. So restoring the balance for cancer care in this COVID-19 era, in the precision era. Thank you so much for a patient hearing and for the opportunity.
Thank you, sir. Thank you, Dr. Ghanshyam Biswas, sir, for a lucid presentation about why to wait for molecular results before initiating therapy. So we'll move on to our next presenter, and she is a pathologist, concerned pathologist at Kingsley Hospital, Nagpur, and she'll be talking on type of liquid biopsies and when to use them maximum. So over to Dr. Gauri Hardas.
Has already shared something about liquid biopsies. So today I am going to discuss a few things about it. So my topic of presentation is types of liquid biopsies and when to use them maximally. Next slide. Over the last decade, the concept of precision medicine has been dramatically renewed in the field of medical oncology. Next, please. So precision oncology is defined as molecular profiling of the tumor to identify targetable alterations. It is very rapidly developing and has entered the mainstream of clinical practice. Next, please. As a consequence of their diagnostic potential, the new technologies highlighted the limitations of current sampling method. So traditional biopsies are invasive. They are associated with many complications and it cannot be performed when tumor site is inaccessible. Next, please. For these reasons, in recent years, new field of oncology research has focused on cancer-derived component circulating in the bloodstream, and detection of these components is known as liquid biopsy. So liquid biopsy is defined as analysis of any tumor-derived material circulating in the blood or any other body fluid like urine, saliva, CSF, etc. There are many biomarkers detected by liquid biopsy, which are ctDNA, that is circulating tumor DNA, CTC, that is circulating tumor cells, ctRNA, microRNA, and exosome. The two most commonly studied biomarkers are ctDNA and CTC, which we are going to see in our next slides. So sample collection. The most commonly used sample for liquid biopsy is peripheral blood, and many commercially available tubes are there like Roche and Streck, but these are costly tubes. So for liquid biopsy, sample can be collected in PDTA tube, but it has to be processed in less than 2 hours. Next slide. Now, what is ctDNA? Apoptotic or necrotic cancer cells release circulating cell-free DNA fragment in the blood, which is known as ctDNA. It represents a fraction of total cell-free DNA released in the blood due to physiological remodeling of the tissue. So currently, FDA has approved clinical use of ctDNA to detect EGFR mutation for non-small cell carcinoma patients who are unable to undergo tissue biopsy or patients with acquired resistance to EGFR tyrosine kinase inhibitors. Now coming to its future application for non-small cell carcinoma genotyping to guide and monitor genotype-directed therapies. As we all know, tissue diagnosis is the gold standard, but it has its own limitations, which we have already seen in our previous slides. So today, only EGFR mutational status is routinely assessed by blood-based test and it has good specificity. However, the sensitivity is imperfect and negative result is confirmed by tissue biopsy. It is also used to detect T790M mutations in patients who are not responding to EGFR tyrosine kinase inhibitor. ctDNA has been widely studied in targeted therapy. Its potential to guide and follow response to immunotherapy is beginning to be evaluated. Tumor mutation burden can be estimated from ctDNA using NGS platform, and it has good concordance with tissue NGS, but its clinical utility is limited due to its high cost. ctDNA is also used to monitor treatment response during immune checkpoint inhibitors therapy. Complete clearance of ctDNA is strongly predictive of good response, whereas its persistence has harmful impact. Few other applications which are likely to emerge in near future are detection of MRD for adjuvant immunotherapy and detection of mechanism of resistance like JAK1/2 mutations. Next, please. Let us see its application in early stage non-small cell lung cancer. Screening is probably the most challenging area in lung cancer. Studies have showed that combining high sensitivity CT scan along with the specificity of liquid biopsy is very promising in high-risk patient or in asymptomatic cases. However, it is limited by the fact that ctDNA shed is either very low or absent in early stages. Also, determining the site is possible only in few cases because lung cancer does not have specific circulating tumor protein. Next, please. Coming to CTC, that is circulating tumor cell. This is the second most commonly studied biomarker. These are the cells shed from primary or secondary tumor which migrate into the vascular system and causes distant metastasis. Next, please. Its current and potential application for non-small cell cancers. CTC detection rate is very low in early stage cancer, making it low sensitive. Also, all the inflammatory lung disease releases epithelial circulating cells. So this low sensitivity combined with poor specificity makes it unsuitable for screening of lung cancer. Studies have established the burden of CTC as an independent prognostic factor in non-small cell lung cancer. High CTC has poor prognosis. Few trials have shown that accurate quantitative follow-up may be difficult due to low number and it should not be used for response follow-up. After listening to so many pros and cons of liquid biopsy, one question is banging on everyone's head that can tissue biopsy be replaced by liquid biopsy? And the answer is no. It will never replace the tissue biopsy fully. Next, please. So take home message, liquid biopsy is a new and valid tool in lung cancer management with potential alternative for tissue biopsy. Tissue biopsy still remains the gold standard for genotyping of lung cancer. When tissue is the issue, try liquid biopsy. But negative test will always need tissue confirmation due to lack of its sensitivity. Next, please. Thank you very much, Amol sir, and organizing. Thank you.
Thank you, Dr. Gauri, for such a sweet and short and sweet presentation about liquid biopsies and when to use them maximum. So we'll move on to our next presentation. This will be given by Dr. Vijay Patil, who is a dear friend of mine and a professor and consultant Department of Medical Oncology at Tata Memorial Hospital, Mumbai. Dr. Vijay will talk about future directions in molecular diagnostics and also on biomarkers. So over to Dr. Vijay.
Good evening all. The topic given to me by the organizers today is to talk upon biomarkers in with immunotherapy. I've taken the liberty to modify this topic and to talk about biomarkers in checkpoint inhibitors, which is more relevant to what we do in practice. Now, whenever we talk about biomarkers, can be of two types. One which predict for efficacy and one which predict for adverse events. For the purpose of this talk, I'm going to stick to those biomarkers which are talking about efficacy. Now we all know checkpoint inhibitors have been used at multiple sites. When we look at biomarkers which predict for their benefit, they can be broadly divided into two types, either tumor-derived or the immune system. And the tumor-derived are the PDL1, tumor mutation burden, the macrosatellite instability, damage repair gene status. The immune status are basically which look at whether you have adequate lymphocytes or not. So ratios of ANC, ratios of ALC, with respect to the reticulocyte counts. If the ratios are low, it has shown that they don't. These patients don't do well. Looking at cytokines which are pro-immunogenic or anti-immunogenic. And looking at tumor infiltrating lymphocytes. And the last but not the least is looking at enteric microorganisms which impact the gut flora and which may have a role to play in future with immunotherapy molecules. Before I go to talk about efficacy, which are the predictors of response, I think it's important that we should have an idea which are the predictors for that the patient may not do well with immunotherapy. Well, hyperprogression is seen with immunotherapy. Basically, there are multiple definitions for hyperprogression, but the consensus, there is no consensus on the definition yet. But most of the papers would say that if the tumor growth kinetics or growth rate exceed twice of what was seen before the treatment. So you started on immunotherapy and the tumor started growing very fast, and the speed of how fast? The speed is double of what it was seen on immunotherapy, then you would label it as hyperprogression. It's mainly seen in patients who have an advanced stage and to a large extent in patients who have lung cancer. I have limited seen this in head and neck cancers or for that matter in urological cancers. But to large extent, this is a phenomena which is restricted to lung cancer patients. If you look at the biology, which are the factors which play a role, expression of MDM2, amplification of genes, EGFR mutation, these are the patients in which you could see that they have some amount of predictive impact. But this predictive impact is not large. Yes, MDM2 is the highest of around 67%. But in others, this predictive impact is below 10%. You have a lot amount of others, which like neutrophil lymphocyte ratios, elevated LDH, Ki67, the profile of CD8 positive T cells, which is there, but not to that extent. So what I wanted to convey is hyperprogression does happen. You need to watch it clinically. At present, we do not have any specific biomarkers which predict us that this patient is going to have hyperprogression. Let's talk about response. And when we talk about response, PDL1 expression seems to be at present the best predictive biomarker which we have. Higher the PDL1 expression in multiple type of immunotherapy molecules, multiple sites, has shown that it leads to better response rates, better PFS, and to a large extent a better overall survival rate. The question arises that most of these PDL1 are accompanied with PDL1 molecules are accompanied with a companion kit, and the companion IHC differs, and we have here 22C3, 28A, SP142, SP263, SP142, E1L3L. Now the question is that each of these molecules at different sites have got approval based upon the cutoffs which are given by these IHCs. It's difficult. Like example in lung also, the IHC recommendations for nivo-ipilimumab are different. Those for pembrolizumab are different, and those for atezolizumab are different. It's difficult to have that much of biopsy to be subjected to multiple types of IHCSs. So obviously it is important to see whether there is any harmonization between all these types of IHCs or not. The Blueprint PDL1 IHC comparison project and the multi-center harmonization study did show that 22C3, 28.8 and SP263 are all consistent and can be reliably, I won't say interchangeably used, but can give you the direction in which the PDL1 expression is in non-small cell lung cancer. Unfortunately, the rabbit clones of SP142 and EL13L are discordant, and so basically if you are using 22C3 or 28.8 or SP263, you can have some amount of interchangeability in these HCSs, but not with respect to SP142 predicting for the other ones. But that is the story in lung cancer. What about in head and neck cancers? And this is a recently published robust analysis of this 5 IHC types on PDL1 expression. And basically this was done in upfront patients, in which you would see that we would have recommendations for 22C3, this is a DACO antibody for pembrolizumab in first line eligibility. And you could see that the number of patients who turned out to be positive, an expression of few when you are using 22C3. It increases to a large extent if you use SP263, and another higher extent if you use the 28.8. The message I'm trying to convey is that these IHC methods may be interchangeable or may help you tell the direction in non-small cell lung cancer at present. Utilization of these in different subsites needs to be studied, and that harmonization needs to be done. Especially in subsites like head and neck cancer, it's better that you stick to the recommended IHC methods. Now, up till now, we have been looking at PDL1 expression with respect to IHC. PDL1 mRNA expression can also be studied, and that can be done by RNA sequencing. It's an interesting development which has happened with PET-CT, where nuclear medicine colleagues now can use something called as 68 gallium Nota NB109 agent, and it can highlight the PDL1 expression pattern in the tumor. As you can see here, when you look at the A375 site, there is not much PDL1 expression, and when you look at A375 here alone, you are not seeing any hotspot. When you're looking at A375H PDL1 stroke A375, there is some amount of PDL1 expression. You could see here that there is some amount of mild uptake which is seen. When I restricting you to A375H PDL1, there is which shows a high uptake, you could see that this part does show very high uptake. So what is this trying to tell you? And this trying to tell you is that in future, it may not be surprised that PET-CT itself can tell us whether the tumor is having PDL1 expression or not. And it may be of interest also. Heterogeneity in PDL1 expression has not been yet described much, and I'm sure that someone studies multiple sections of tumor we may have heterogeneous expression of PDL1, and we may have discordant expression of PDL1 between the different metastatic sites, and having a radiological imaging, so in this case, a nuclear imaging can help us. It also opens up avenues for the future. And you know that you have a target which you can be helpful and you can go and hit PDL1. Adding a radionuclide, a radioactive small molecule to that target may help us to eliminate the PDL1 cells, PDL1 positive tumor cells in future much more better. Now let's talk about tumor microenvironment. Up till now, we talked about the expression of PDL1 on the tumor cells. What about the expression in the tumor microenvironment? And this is Shen's classification, and this was done by this extensive work has been done in urothelial cancer by Dr. Shen on this and his lab, basically, where they classify the tumor microenvironment immune types into 4 types. The first type is there is the presence of lymphocytes, tumor-infiltrating lymphocytes, plus PDL1 expression is there. And this is the side that is also known as the TMIT type 1, and this is the best sensitive to immunotherapy. As opposed to the others, they are less sensitive to immunotherapy. And this is a snapshot of the things which we saw in the urothelial cancer. This is TMIT1 expression. You could see that this is the highest expression of PDL1. Not much difference in respect to the somatic mutation burdens. Not much difference to the somatic mutation burden with respect to expression also. Why do you see a change is the TMIT1 have seen that they have a differential expression of gene, especially expression of RB1 gene. The TMI22 has an expression of FGFR3 genes. What is the message here? The message here is that tumor microenvironment divided into classifications of 1 to 4. The 1 is the one which is going to predict for the best response to checkpoint inhibitors, as opposed to 4, which would predict for a not so good response to checkpoint inhibitors. Let's come out to the next thing which we commonly use in practice, the tumor mutation burden. What's the definition? The definition is the density of non-synonymous mutations which occur in the coding region of the tumor genome, and is calculated as mutations per DNA megabase. But for those who are, it is simply we are looking at extra somatic mutations which are there, which means that germline mutations should be removed before we go and count for this extra somatic mutation. What I mean by extra is the higher the number of somatic mutations. The problem is most of the tumor mutation burdens scores which have got validated got validated on Western populations. There are very few data sets from India which were used for that validations. Ethnicity would make a difference in the amount of mutations you have. Certain mutations which are seen in our population as germline mutations may not be seen in the Western population. Okay, so the application of this, scientifically speaking, is limited because our data is limited with respect to what is the tumor mutation burden which is there in our society. What's the gold standard? The gold standard is whole exome sequencing, but none of us use that in our clinical practice. Hence, we use NGS. The cutoffs are variable across variable sites. The commonly used ones in non-small cell lung cancer is about 10 mutation burden per DNA megabase space. Interestingly, there is no correlation between PDL1 and tumor mutation burden, which means independent of PDL1 expression, the tumor mutation burden expression will be different. And if there is a high tumor mutation burden expression, they do respond to immunotherapy. Let's come to another type called the mismatch repair deficiency. Mismatch repair is a system which helps you to repair defects which happen like mismatch, insertion, deletion during DNA replication. Now there are 4 vital genes, the MLH1, MSH2, MSH6 and the PMS2. If 2 or more of the genes get inactivated, the tumor is called MMR instable, MSI, macrosatellite instable. How common or uncommon it is across? If you see in certain tumors like that of the colorectal cancers or the endometrial cancers, this is pretty high. In certain tumors like head and neck cancer, this stands at around 1%. The important thing is, irrespective of whether you have which side, it is a tumor agnostic and site agnostic finding. So if you have mismatch repair deficiency, then you would respond to pembrolizumab, and that response can be as high as 40 to 50%. And the objective response rates in non-colorectal cancers is actually as high as 70%. And the median time to response and the duration of response are beyond 1.5 to 2 years. And this is again just to show you, this is the results from Keynote 177 when pembrolizumab was given in those patients who had mismatch repair gene deficiency, irrespective of whether they were colorectal or non-colorectal cancer, they did better with pembrolizumab. So this is an important predictive marker which predicts for nearly 70% response rates with the checkpoint inhibitors. There are other tumor factors like P10 activation. A loss of P10 inhibits a T cell mediated tumor killing, and hence if it is lost, it gives poor efficacy to immunotherapy. Pole mutation, what is pole? It's DNA polymerase epsilon catalog subunity. A loss of pole as opposed to loss of P10 raises the tumor mutation rates, and hence there is significant increase in the neoantigens and they do respond to immunotherapy. Co-mutation in KRAS STK11 has been shown to lower the response rates, at least in non-small cell lung cancer, as opposed to KRAS, presence of KRAS P53 mutation or alone KRAS mutations. Presence of EGFR mutations, or that matter even of ALK mutation, driver mutations, even if PD-11 expression is high, they do not respond that better to immunotherapy. But TAT mutations, TAT1 mutations show significantly higher response rate, and this is up to the 70% high. At present, quite a few like pole is been used in endometrial for classification. It's a good predictor for the response to immunotherapy also. Problem is, none of these are like having a 80%, 90% predictive. Most of them have predictability in the range of 50 to 60%. So as you can see in TET mutant, even if they are not there, 30% of them respond, which actually is not a bad number in patients who are receiving immunotherapy post multiple lines of therapy. And hence none of them have been able to make an impact as has been made by, to that matter, by PD-L1 tumor mutation burden or macrosatellite instability. Up till now, we have been covering those with tumor cells or those with tumor microenvironment. We have not covered those things which lead to intestinal microflora. I won't be covering those peripheral blood tests because it's very flimsy data which is associated with this, with multiple retrospective analysis showing that this ratio is good, but validated, it's not been much validated. But there's interesting things going on, intestinal microflora. Now, when we talk about gut microflora is responsible for the immunogenic activity that happens in the gut, and also it does stimulate or depress the activity in general what is happening in the blood. There is favorable predictive bacteria like bifidobacterium, the fecalobacterium, and the bacteroids, which have shown that presence of them, especially in patients with melanoma, that they have a predictive effect on immunotherapy. And this is the way our gut microflora changes. So when we look at the alpha diversity of the gut flora, it starts increasing, and then in age-related dysbiosis, it decreases. And the beta diversity keeps decreasing as we go. And most of this has to do with our diet compositions, our travel habits, and our eating habits, and how hygienic we are. And what we see is that the immune senescence increases as the alpha diversity decreases and the beta diversity again increases, which means that the chances of responding with old age decreases with the age. And one of the reasons is that polypharmacy antibiotics which are given in this. And there are multiple strategies to modulate with your gut microflora, which are in clinical trial designs, multiple phase 1, phase 2 trials, in which we are trying to have fecal microbiota transplantations, probiotic, prebiotics, giving plants, giving more types of dietary fibers, trying to optimize it so that how we can optimize the gut microflora to get it, let's say, useful activity. Does it help? Just, I think a week back, this paper on 20th February has got published, in which a phase 1 study was done. What was done was nivolumab and ipilimumab patients plus ipilimumab who were receiving it for RCC were randomly assigned to receive a bacterial supplement or not receive a bacterial supplement. The bacterial supplement was Clostridium butyrium, which is the butyrate anaerobic spore forming bacterium, which was given. And you could see that those patients who received this, they had much better progression-free survival and overall survival. It's a small phase 1 of around 29 patients. It's got published in Nature. What does it show is it gives a proof of concept that this intervention might help, and this is something which we may see in future. That was my last slide. Checkpoint inhibitors are going to be used to a large extent, and more amount of research will be required. And interestingly, the use of these biomarkers may not only be predictive, modulation of these biomarkers may, like the modulation of the gut flora, may come into the future, which may help us to have better results. Thank you.
Thank you, Vijay, for your excellent presentation about future direction in molecular diagnostic. What I like most is about the, the PET PDL1. So, Vijay, what exactly is this PET PDL1 and how we are gonna see in the future regarding this PET PDL1 expression? Vijay, you there? Vijay? Vijay? Vijay, can you hear me?
I think that was a recorded one.
Okay, fine. Okay, so we move on to our next presentation and our next session, which is basically on management of EGFR positive NSCLC, and this session is sponsored by Novartis Oncology. For this, I would like to call upon Dr. Nikhil Pande, who is a senior consultant medical oncologist at HCG NCHRI Cancer Center, Nagpur, and he'll talk on capmatinib, unlocking the unmet need in MET-X protein skipping NSCLC. So over to Dr. Nikhil.
Thank you, sir. Thank you. I hope I'm audible.
Yeah, Nikhil.
So, thank you, sir. I'll be talking about capmatinib. Next slide. So, let's talk about the MET mutation in NSCLC. So, it is reported to be mutually exclusive for other established molecular drivers, including EGFR mutation or ALK translocation. MET mutation is a splice site leading to exon 14 skipping result in MET juxtamembrane gain of function alteration, originally discovered in actually SCLC and later in NSCLC adenocarcinoma. So MET exon 14 mutations occur in 3% and 5 to 22% of other NSCLC subsets and are linked to early stage diagnosis and older age. Next slide. So basically it is associated with worse survival outcomes, and it is an independent prognostic factor that predicted worse survival compared in patients without MET mutation. So this is MET positive and MET negative. You can just see the MET positive graph is very bad. And OS in lung cancer adenomas, if you look at the OS, it is a similar according to MET mutations, wild type versus MET mutated. Next slide. It is also a prognostic factor for a poor response to immunotherapy. And in a retrospective analysis of 147 patients with MET mutation, 24 patients who received immunotherapy were evaluated for response. The overall response rate was a measly 17%, median PFS of almost non-existent 1.9 months, and median OS of 18.2 months. Individual case reports suggest that pembrolizumab might not be effective for NSCLC with high PD-L1 expression and MET mutation. Next slide. So inhibition prolongs survival in MET mutated stage 4 NSCLC. So OS of stage 4 patients who never received a MET TKI, the median OS of 8.1 months versus OS in the similar groups who received a MET TKI is 24.6 months. So, and 10.5 months for patients with MET mutation only, and 5.2 months for patients with MET mutation and concurrent amplification also. And 24.6 months for patients who receive a MET TKI, either crizotinib or glasnatinib or capmatinib. Next slide. Capmatinib is a selective MET inhibitor. It is an oral, ATP competitive, highly potent, selective and reversible inhibitor of MET kinase. More than 10,000-fold selectivity for MET receptor kinase when assessed against a panel of 55 other human kinases. Crosses blood-brain barrier showing preliminary brain activity. Potent blockade of MET activation in cell-based functional and biochemical assay as well as in vivo models. Compared with other agent, capmatinib is the most potent inhibitor against MET exon 14. Next slide. In a geometry mono 1 study design, multi-center open label phase 2 trial evaluating the safety and efficacy of single agent capmatinib, patients were treated with capmatinib at 400 mg in various cohort in an increasing dose range. And these were patients who were more than 18 years, any histology, EGFR wild, ALK negative, MET dysregulation by central assessment, PS less than or equal to 1, and more than 1 measurable lesion as per RECIST. Next slide. The study objective is, primary objective was to demonstrate anti-tumor activity of capmatinib, and the endpoint was ORR as assessed by BIRC. And key secondary objective was to duration of response, and the other secondary endpoints were anti-tumor efficacy, evaluate OS, safety profile, and characterize the PK. Next slide. So this was the patient characteristics baseline for cohort 4 and cohort 5B. This is the dose at 400 mg. Next slide. And treatment naive cohort, which was the cohort 5B, which had 28 patients and prior lines of therapy 1, 2, and 3, almost 74% had received at least 1 line, 23% received 2 lines, and 3% had received 3 lines in cohort 4. Next slide. So best overall response in cohort 4, in the pre-treated cohort, there was 1 patient in the CR arm. There were almost 42% PRs, 30 to 36% of stable disease. But the overall response rate of around 40.6 or 43.5 as assessed by investigator was a significant improvement. Mind you, this is the pre-treated cohort. Next slide. But if you look at the cohort 5B, which is the treatment naive cohort, you look at the overall response rate of almost 68% versus investigator assessed of 61%, which is a significantly better responses as compared to the treatment pre-treated patients. Next slide. So tumor shrinkage per BIRC. So deep responses were observed in majority of the patients across both cohort 4 and 5B. That is, the responses were good. Next slide. The duration of response, median duration of response was 9.7 months in cohort 4, that is the pre-treated cohort, and 12.6 months in cohort 5B. Mind you, if you remember the previous slide wherein MET who were not treated did have a very poor PFS. Next slide. And if you look at the PFS, it was 5.4 months in the pre-treated cohort and 12.4 months in the cohort 5B. It was 1.9 months if no MET-directed treatment was used in the previous study. So this is the swimmer plot for responders. Rapid and durable responses across both cohort 4 and cohort 5B, with onset occurring at first tumor evaluation after initiating capmatinib in 82% of the patients in cohort 4 and 68% in cohort 5. It has a confirmed activity against brain metastasis with 13 evaluable patients with brain metastasis baseline. 54% had an intracranial response. 1 had complete resolution in 3 lesions, stabilization in 4 lesions, and intracranial responses were as fast as responses in extracranial lesions. And all 7 responders in the brain had an intracranial response at the first evaluation. 12 out of 13 patients had intracranial disease control, which is a good intracranial activity. If you look at the tumor shrinkage by MET alteration, deep responses, which were already shown, were independent of MET mutation, leading to MET exon 14 or co-occurrence of MET amplification. Next slide. So, capmatinib 400 mg BID. This was a capmatinib in the Geometry Mono 1 study. Next slide. So overall, when you look at it, 67.7% response rate and 98.3% disease control rate in the first line. Next slide. 52% and 41% response rates for patient in second and third line respectively. Next slide. And the majority of patients experienced a tumor response at first evaluation after initiating capmatinib with durable responses. Next slide. So a clinically meaningful OS of 20.8 months in the first line, cohort 5B, and 13.6 months in the second and third line cohort was also observed. Peripheral edema, GI symptoms, and increased blood creatinine were the most frequent adverse effects, which is easily manageable. Mind you, the grade 3 or 4 of them were at a significantly less, peripheral edema being 10%, but nausea and vomiting being only 2.5%. Next slide. So conclusions, the preliminary efficacy of expansion cohort are comparable to those reported for other cohort B. In pre-treated patients, the ORR was 52% in the second line and 41% in the second and third line. Clinically meaningful median OS of 21 months and 13.6 months in the treatment naive and post-treatment. And the manageable safety profile of capmatinib remains unchanged based on updated safety results. And the updated results further confirmed MET exon 14 as a targetable oncogenic driver in NSCLC. Next slide. I thank you, and I hope I have completed on time.
Yeah, Nikhil. That was an excellent presentation and on-time presentation. So about unlocking the unmet need in MET exon 14 NSCLC. So we move on to our next presentation, which will be given by Dr. Amit Agarwal, who is the Assistant Professor, Department of Medical Oncology, AIMS Raipur, and he'll be talking about ALK inhibitors. Agarwal.
Yes, sir.
Yeah. So, Dr. Amit, yeah.
Yes. Sharing my slides. Sir, my slides are visible?
Yeah, Amit, it's visible. Dr. Amit, it's visible.
Good evening, everyone. First of all, I want to thank the organizers for giving me this opportunity. I'll be talking about ALK inhibitors, particularly between the lorlatinib versus alectinib. So we know that the ALK mutations are seen in around 2 to 5% of advanced non-small cell lung cancer, especially adenocarcinoma. There is ALK rearrangement, and the most common is between EML4 and ALK-G. We have different TKIs available, and the basic mechanism of action is to inhibit the downstream signaling pathways that ultimately reduces the cancer cell proliferation. So this is the timeline of FDA approval of various ALK TKIs. In 2007, the EML4 ALK rearrangement was first discovered, and in 2011 was the time where the first TKI for this ALK positive NSCLC was approved, the crizotinib, and then the evolution started, and since then we have got multiple various treatment options for this cancer. So we'll be talking about lorlatinib versus alectinib because we know that both have shown good clinical activity in phase 3 trials, and in various forums it is often discussed which to choose. So I'll try to figure out what is the available data about both the molecules and where we can move in future. So these are the points for comparison. Without wasting much time, I'll start with the first point, the chemical structure and mechanism of action. We know that alectinib is the second generation ALK TKI, and as compared to first generation TKI, it has more activity against certain mutations which are seen after treatment with crizotinib, and more CNS penetration to other agents like crizotinib and ceritinib. So it actually binds to tyrosine kinase domain of ALK, preventing the binding of ATP and inhibiting the autophosphorylation. So downstream signaling pathways are inhibited. Actually, there is replacement of benzofuran fragment with an indole moiety as compared to crizotinib, and that ultimately leads to more efficacy and more activity against certain mutations. But still, it is ineffective against certain mutations. This typo should be ineffective. It is ineffective against certain mutations like G1202R, where ATP actually is able to bind, and alectinib could not bind to this mutated ALK protein, and ultimately there is continuous activation of signaling pathways. So lorlatinib is answer to these mutations, as well as it is more effective against certain mutations and more number of mutations. So it is a third generation TKI, and it also shows good CNS penetration. We know that crizotinib, ceritinib are the agents which are actively exported out of the blood-brain barrier, but lorlatinib has good CNS penetration, and that's why it is effective against it. It shows more intracranial responses as compared to other agents. Now, coming to history of drug development and FDA-approved indications, these are the FDA-approved indications for both the agents. We'll come to this again. So this was the first initial papers of the preclinical activity of alectinib in ALK-positive cancer cells. This was the year 2011, and mind you, at that time, even crizotinib was not approved for clinical use. The phase 3 trial of crizotinib was ongoing at that time. So this shows what we see in the clinical use or in the market today is the result of years and years of hard work behind the scene by the pharmaceutical companies, by the clinical researchers. So in 2011, the preclinical activity of alectinib against certain ALK-resistant mutations was shown, and then the era started about its various phase 1, phase 2, phase 3 trials. So this was the first phase 1/2 trial, was a Japanese trial, and it showed 93% objective response rate. It was published in 2013. Then again a phase 2 trial of a North American study, which was published in 2016, which showed which was done in around 87 patients, and all these patients had prior crizotinib, and almost 3/4 had prior chemotherapy also, which showed objective response rate was around 48%, and even in updated analysis, the median follow-up was of 17 months. The objective response rate was 52 months. Then came the phase 3 trial, first the Japanese one, JLX. It was a randomized open-label phase 3 trial, around 200 patients. Here, the dose of alectinib was 300 mg BD, which was approved for the Japanese population, and the primary endpoint was PFS. The PFS was not reached in the alectinib arm as compared to crizotinib, where it was 10 months, and the grade 3, grade 4 events, adverse events were less with alectinib. This was published in 2017. Then in the same year, ALEX trial, which was a global study, randomized phase 3, around 300 patients, and here the dose of alectinib was 600 mg BD. The endpoint was again PFS, and the PFS was 68% versus 48%. Objective response rate was also higher in the alectinib arm. The grade 3, grade 4, grade 5 adverse events were less with alectinib, even with the dose of 600 mg BD. So these trials actually established the alectinib as the first line. In 2015, after the phase 2 trial, it was approved for the later lines of therapy, and in 2017 as the first line therapy approval. Coming to lorlatinib, this was the first paper of preclinical activity for the activity against the ALK resistant mutations after the first and second generation ALK inhibitors, year 2015, and at that time alectinib wasn't approved even for later lines of treatment. This was the first, the phase 1 human clinical trial, which was done for both ALK as well as ROS mutation positive patient. Around 41 patients were ALK mutant, and it showed around 46% of objective response rate. But the important feature was that there were significant side effects like hypercholesterolemia, hypertriglyceridemia, peripheral neuropathy, and peripheral edema. These patients were heavily pretreated. Around 50% had prior received 2 or more TKIs, and around 72% patient had CNS metastasis also. So it showed good response, but at the cost of significant adverse effects as well. Year was 2017, and then this study was continued as the phase 2 expansion cohorts, and in various cohorts. Actually, in the phase 1 trial, various different doses of lorlatinib starting from the 10 mg OD were used, and ultimately dose was decided for phase 2 trial was 100 mg OD, which is the standard dose currently. The primary endpoint in the phase 2 part of the study was overall response, and what they saw that the patient who had received at least one ALK inhibitor TKIs, the objective response rate was 47%, and the adverse effects profile was similar. Then the phase 3 trial, Crown trial, it was a global randomized phase 3 trial, nearly 296, nearly 300 patients. The primary endpoint was progression-free survival. And the 12-month PFS was 78% versus 39%. The hazard ratio is excellent, 0.28. And the objective response rate is 76% versus 58%. And the important highlight is the patient with measurable CNS metastasis, the intracranial response rate is 82% versus 23%. The side effect profile is same what we see earlier, but the rate of grade 3 for adverse events are higher in the lorlatinib arm, 72% versus 56%. Based on these trial results, the lorlatinib got first FDA approval for previously treated patient in 2018 and as first line therapy approval in 2021. So now, whether there is any direct comparison data, head-to-head trial, no, but we have two meta-analysis comparing lorlatinib versus alectinib. In this meta-analysis, actually, there is comparison of lorlatinib, alectinib, and brigatinib. This was the inclusion criteria for this meta-analysis, and they selected ultimately these 5 studies: the LX, Crown, LSCR, JLX, and Alta-1 trials. The primary outcome for this review was PFS. Now we will stick to the lorlatinib versus alectinib part. The PFS analysis, we can see here the hazard ratio for lorlatinib versus alectinib is favoring lorlatinib. The hazard ratio is 0.59. In the untreated patient who were ALK inhibitor naive and chemotherapy naive, and even in patients who are ALK inhibitor naive but not chemotherapy naive, the lorlatinib is shown good activity. The hazard ratio is 0.65. If we talk about the various subgroups, we can see here, apart from the non-Asian population, where this hazard ratio is 0.39, rest all bars are crossing the unity. So probably those subgroups are not showing any significant difference between the two agents, but here non-Asian populations, there is significant difference between the lorlatinib versus alectinib, favoring lorlatinib. And other than that, there was no significant difference observed among lorlatinib and alectinib in the overall confirmed response rate, intracranial confirmed response rate, and the side effect. Then again, another meta-analysis. Here they choose 8 studies for the comparison of lorlatinib against other TKIs. You can see here in terms of PFS, the lorlatinib is favored against all other agents like crizotinib, ceritinib, brigatinib. But in case of alectinib, the hazard ratio is nearly 0.7, but the bar is crossing unity. So probably statistically not significant. If we divide into non-Asian and Asian patient, obviously there is significant difference in the non-Asian population. Bar is not crossing unity here. The hazard ratio is 0.38. But in Asian population, again, it is actually favoring probably alectinib more. If we talk about the patient who are with or without CNS metastasis, in patient with CNS metastasis, the it is favoring towards lorlatinib but crossing unity. Again here it is crossing the unity and but favoring lorlatinib. And in terms of OS, actually there is no significant difference between all the agents because all the bars are crossing unity. If we see the comparison between lorlatinib and alectinib, the diamond is favoring the comparator arm, that is alectinib. If we talk about the adverse events, it is favoring alectinib, which is expected as seen in other trials. So probably lorlatinib is more effective in non-Asian population, maybe more effective in patient with CNS, with the existing CNS disease, and alectinib is shown superior safety profile as compared to lorlatinib. Now, cross-trial comparison is not the standard thing to do, but we don't have any choice. We'll compare the ALEX trial and CROWN trial here. The design-wise, number of patient characteristic, the comparator arm, both are nearly similar in both the trials. The only thing difference is the brain metastasis is at baseline. 40% of patients in ALEX trial were having brain metastasis at baseline, as compared to 26% in CROWN trial, and 17% of patients had previous brain irradiation in ALEX trial. The primary endpoint was similar in both the trials. Here the survival curves in the ALEX trial, significant difference between alectinib and crizotinib arms. The hazard ratio was 0.47. And in subgroup analysis, most of the subgroups are favoring alectinib as compared to crizotinib. The cumulative incidence of CNS progression was 41% in crizotinib, while it is 9% in alectinib. This is the curves from CROWN trial. Here the PFS was significantly higher in the lorlatinib arm. The hazard ratio was 0.28, and the cumulative incidence of CNS progression, it is 33% in crizotinib arm versus 3% in the lorlatinib arm. Talk about the side effects. We can see here in the ALEX trial, alectinib showed around 28% patient had serious adverse events, and around 40% patient had grade 3 to grade 5 adverse event. The common grade 3 or more side effects were transaminitis, hyperbilirubinemia, weight gain, anemia, nausea, etc. While in the CROWN trial, lorlatinib showed more number of adverse events. Around 70% of patients had grade 3 or more side effects, and the most common grade 3 or more side effects were hypercholesterolemia, hypertriglyceridemia, edema, weight gain, hypertension, etc. So side effect is definitely more in lorlatinib, and that remains an important concern while choosing the drug. So comparison of outcomes for objective response rate is in the tunes of 70 to 80%. The median PFS was 35 months in alectinib, ALEX trial for alectinib, while it is not reached in CROWN trial for lorlatinib. PFS is obviously superior in the CROWN trial for lorlatinib. The intracranial response rates are nearly similar. The 12 months cumulative incidence of CNS progression is low for lorlatinib. Lorlatinib has probably superior CNS activity, but obviously the adverse events are more in the lorlatinib arm. So now, why to choose lorlatinib as first line and why to choose alectinib as first line? I cannot draw a definite conclusion, but these are certain points which can guide us while choosing the therapy. Lorlatinib has greater PFS benefit in terms of better hazard ratio. It showed better CNS activity, and it is more active against ALK-resistant mutations, more efficacy, and as well as it is active against more number of mutations, and also it requires single daily dosing. While someone can say we will choose alectinib as first line, so their argument could be it has shown better safety profile, and the issue of sequencing, what to give after lorlatinib, because we know that after alectinib there will be certain mutation which can be controlled by lorlatinib, but after lorlatinib there is especially the issue of complex mutation and what we will offer to those patients. And but how common are these resistant mutations? We are saying that lorlatinib is effective against more number of ALK resistant mutations, but whether these mutations are really very common at baseline and they need lorlatinib, all the patients, we don't know. So this is the common diagram which is shown in various forums regarding the sequencing of ALK inhibitors. Currently, most of the doctors are prescribing alectinib as the first line, but lorlatinib has come into the picture. The PFS is not reached. The problem is what we will offer after lorlatinib. So that remains a question here. And there is another problem of resistance, which I told. We know that similar to EGFR, there is also various mechanism of resistance against ALK TKIs. This is the resistant pattern.
We can't hear you.
Hello.
Yeah, please tell. Yeah.
This is the resistant pattern after crizotinib, and this is the diagram which shows various resistant mutations which are seen after use of various ALK TKIs. We can see here lorlatinib is effective against most of these mutations, but really whether these mutations are common at baseline, we don't know. This is a pooled analysis from 2 prospective trials, whether they showed that post crizotinib around 25% patient had different mutations, ALK mutations, and post use of alectinib, around 53 patients who had progressed after alectinib shown different ALK mutations. So we definitely know we'll have certain mutation after use of each ALK TKIs, and we need certain thing to act upon. So is there anything to offer post lorlatinib? Probably this could be the answer, gilteritinib. It is the paper from a preclinical study, and gilteritinib has shown significant activity against mutations which are seen after lorlatinib, progression on lorlatinib. So in future, we might see certain phase 1, phase 2 trials regarding this agent. And this was about the advanced NSCLC. Just to give you a hint of ongoing trials of ALK TKIs in the curative setting, there are 2 trials. All-neo trial is going on for alectinib in the neoadjuvant setting, and another trial, ELINA study, is going on for adjuvant alectinib. No one trial is offering currently ongoing for lorlatinib in the curative setting. So to conclude, we have multiple first-line treatment options available for advanced ALK-mutated non-small cell lung cancer. Cost of treatment, toxicity profile, ALK kinase resistant pattern are the important determinants for deciding which therapy to choose. But since this therapy is offered for a long period of time and we want to have good PFS, so real-world toxicity data and long-term patient-reported outcomes will guide us which agent is safer and which improves the quality of life. At least it should not hamper the quality of life, even if it does not improve the quality of life. And in future, biomarkers that can identify patients with potentially more aggressive or CNS tropic ALK tumor biology will help inform which patient may most benefit from which treatment. Thank you.
Yeah. Thank you, Dr. Amit Agrawal, for such an excellent talk. So due to lack of time, we'll move on to our next presentation. This will be by Dr. Gautam Goyal, who's a senior consultant medical oncologist at Max
Excuse me,
Hospital,
sir.
Mohali.
Excuse me,
Yeah.
sir. Dr.
Yeah.
Gautam will join late. So can you invite Dr. Akash Tiwari?
Yeah, sure. So as Dr. Gautam is busy somewhere, can we have another talk by Dr. Akash Tiwari, who is a consultant medical oncologist at Shelby Hospital, Indore, and he will talk on rare mutations of lung cancer, basically BRAF. So over to Dr. Akash Tiwari.
Thanks for the invite. And thanks, Amit, for that wonderful talk. So, am I audible and is the screen visible?
Yes, sir.
So, we will be discussing, there will be several talks on adenocarcinomas that have driver mutation. One of them is BRAF, and our talk would be focused on this, and we'll try to keep it short. So we know that BRAF is a part of the MAP kinase pathway. MAP kinase pathway plays a very key role in cellular proliferation, and a lot of oncogenes that we find that we target or are potential targets happen to be part of this pathway. So it could either be the receptor EGFR to the KRAS, BRAF, MEK, PIK3CA, PTEN, and BRAF is one of them, and this mutation is seen in several cancers. Therapeutically, it is very important in melanomas, thyroid cancers, and now in non-small cell lung cancer. So we see BRAF mutations in almost 1 to 4% of all non-small cell adenocarcinomas, and these mutations are usually exclusive. So we do not find them overlapping with KRAS or EGFR or ALK. The majority of the mutations in the BRAF are in V600E, which accounts for almost 50 to 70% of these mutations. And for our respite, this is also the mutation for which we have a target. The second thing is that we know that EGFR, ALK mutations are predominantly seen in women, young people, non-smokers. But BRAF mutation does not have a very strong correlation with any age group, any gender, any stage of diagnosis or smoking status. And hence, this focus that all patients with metastatic CA lung should be tested in a multi-gene panel. So what are the types of mutations that are available? We have talked this earlier. V600E is the most common mutation, and it is also the targetable mutation. For us clinicians, every other mutation would be a non-V600E mutation because in the current time frame, at least they are not relevant for us for therapeutic point of view. As we have seen the MET mutation earlier, BRAF mutated tumors do bad as compared to the wild type tumors in terms of both the response rates, the progression-free survival, the overall survival. They have poorer response to chemotherapy. So if we grossly want to look at the responses, so wild type tumor say has a overall response rate of almost 48%. V600E has almost half that overall response rate. If the median PFS in a wild type tumor with chemotherapy is 6.7 months, that in BRAF mutated tumors is 4.1 months. Similarly, the median OS is also almost 2/3. And hence, we see that though it is a smaller subgroup of tumor, but it is a subgroup of tumor that is doing poorly on the standard of care, and hence we need a different standard of care. The other issue with BRAF mutated tumors is that a large proportion of these tumors, so almost 1/3 of these tumors, of course these are older series, 1/3 of these tumors would receive best supportive care as first line care. So they present sick. And almost 2/3 of them, so 57, almost half of them will not be able to receive a second line therapy because they are not fit at that time. So how do we currently practice is that patients with poor fitness, we give them best supportive care. With good fitness, we either offer them IO plus, we offer them an IO plus chemo combination followed by maintenance. And once they progress, we can offer them either immunotherapy or other single line chemotherapies. This landscape has predominantly changed by the availability of the molecular testing. So historically, how we did it, even in our training days, was we did it sequentially. So we did EGFR test first, then ALK, then ROS, because of the availability, lack of availability of the test, and otherwise because of the limited targets that were available. Currently, the practice across the board is to do a broad molecular profiling, which includes multiple targetable driver mutation genes. So both ESMO as well as NCCN pushes us to do a broader molecular profiling rather than sequential testing. Though the recommendations for predominantly were for EGFR, ALK, ROS, and BRAF, but we know that since these guidelines also multiple targets have come up, and hence a 12 gene panel that we usually use is a way to go for the tumors that we are seeing currently. The other reason why we need to do a BRAF testing is that we had initially seen that it is difficult to find which subgroup of patients would have a higher proportion of BRAF because BRAF mutation does not very strongly correlate with clinical risk factors like age, gender, smoking history, etc. Also that these tumors are more aggressive, they do better with targeting, and if we do not target them, they have poorer outcomes as compared to the wild type tumors. So here came the data of dabrafenib trametinib. Dabrafenib is a reversible inhibitor of BRAF V600E, whereas trametinib inhibits the same MAP kinase pathway a step lower at the MEK1, MEK2 level. This drug is currently indicated for patients with advanced non-small cell lung cancer with a BRAF V600E mutation. We all know that for a non-BRAF V600E mutation, these drugs are not indicated. So the combination therapy is currently the way to go, because we know that if we do isolated BRAF inhibition, the tumors usually overcome the BRAF inhibitor monotherapy and develop resistance, and hence there is a synergistic action between the BRAF inhibition and MEK, and it is the preferred way of usage. So when the approval trial was a phase 2 trial, there were 3 cohorts, cohort A, B, and C. A, only dabrafenib or only BRAF inhibition was used in patients who were BRAF V600E mutation, who are fit, who had no prior exposure to a BRAF or MEK mutation, and they had symptomatic stable mets. So cohort A was patients who had received monotherapy and had progressed on more than 1 line of chemotherapy. They were a pre-treated cohort. Cohort B was also a pre-treated cohort, but here a combination of dabrafenib plus trametinib was used, as we know that the combination acts synergistically. Cohort C was a treatment naive cohort. The primary endpoint was the overall response rate, whereas the secondary endpoints were PFS, DOR, OS, safety, and population pharmacokinetics. So what we see broadly is that baseline characteristics of cohort A, B, and C have a similar pretense. So they have similar distribution of men, women, of various ethnicity. They are usually ECOG PS 1 and 2. A large proportion of them are smokers, and almost 1/3 of them are non-smokers. And majority of them are adenocarcinoma. So this is a theme that we'll see in all baseline characteristic tables of these tumors. So cohort A is similar. Cohort B, again, we see that men, women distribution is almost equal. They are fit people. Majority are adenocarcinomas. Almost 1/3 are never smokers. 2/3 are smokers, either former or current. Similarly, in cohort C, we see a similar picture across the board, though there were more females in this group rather than the other. But of course, it would not determine the outcomes from it. So how we went ahead is that in these patients, cohort A, B, and C received dabrafenib trametinib, and subsequently the primary endpoint of overall response rates was assessed. So in cohort A, the overall response rate was 33%. So it is still good for a tumor that has progressed on first-line chemotherapy and has a BRAF mutation, which otherwise signifies a poor outcome. But as we will see in subsequent slides, this response rates were lesser, and the PFS was around 5.5 months. But the patients who responded had a duration of response around 9.6 months. In cohort B, the overall response rate was 63%. So it was almost twice that we see when only one drug was used, dabrafenib, trametinib, and the duration of response was around 9 months, similar. We see similar data that overall response rate was around 63% in cohort B, the tumor which were pre-treated, but still who were treated with a combination of dabrafenib, trametinib subsequently, including a CR. And these responses were long-lived. So so most of the patients who responded had a median duration of response of almost 9 months, which is very encouraging. We see in cohort B, the PFS was almost twice that in cohort A. So when we treat the patients with a combination of dabrafenib, trametinib, not only that they have almost twice the response, the PFS is also double. Cohort C, these were treatment naive patients who were treated with combination of dabrafenib, trametinib. The overall response rate was around 64%, with the median duration of response of around 10.4 months. So the median duration of response is similar in both cohort A, B, and C, which shows that patients who respond, they almost respond to similar lengths, but they have higher chances of responding and a longer duration of control if they are treated with these with a combination and they are treated with it upfront. So when we see the number of patients, the overall confirmed response rate was around 64%, and the median duration of response was 10.4 months, and a large number of these responses were ongoing at the time of the end of the study. The median PFS was 10.9 months, which was almost double the PFS of the tumors that were treated with a single agent, but similar to the patients who were treated in frontline or they were given in a pre-treated cohort. So the second issue that comes with a drug, so we know that BRAF mutated tumors do poorly. We know that we should test for them, and whenever we find BRAF mutated patients, we must treat them with targeted medicine, and as in all tumors with driver mutation. Now the next issue with using a drug is in the sense of toxicity. So when dabrafenib is used as a monotherapy, the predominant side effects are that of pyrexia, asthenia, decreased appetite, cough, fatigue. And these side effects are actually amplified once we use it in combination with dabrafenib or trametinib. Despite of the fact that these side effects are amplified and almost half of the patients have grade 4 toxicity, but they have a low discontinuation rate. So only 14% of these patients would stop the drug. Only almost 30-40% patients would require a reduction in the dosage. And when we use the combination, as we see, fever remains the most common side effect that is seen in almost 46% of the patients, followed by asthenia, chills, peripheral edema, rashes, nausea, vomiting, diarrhea. And this figures remain the same despite of the fact that the patients were given this drug upfront or in after subsequent lines of therapy. So how do we treat patients with fever? And this is probably the most important thing that one should know while using the drug. So if a patient develops fever, it needs a workup for infection, discontinuation of the drug, initiation of the antipyretic, and a decision on dose reduction versus oral corticosteroids. And this is what we'll read in the subsequent slides. So if any patient develops fever, we must do the lab work to see for infections, to see for renal dysfunction, and other complications that may happen. If it is the first event, we stop the drug, interrupt dabrafenib. We may continue trametinib and give these patients antipyretics. Once the fever resolves, we restart dabrafenib and almost the same dose. In the second event, we stop the drug, so rest of the process remains the same, But here we consider starting corticosteroid. So there is this study, it is not quoted here, that initiation of corticosteroids had better control on pyrexia, even better than dose reduction. So we feel that sometimes starting corticosteroids may help us giving the patients the same doses that we want to. In subsequent events, we interrupt dabrafenib. This time when we start dabrafenib, we started at a 1 dose lower level, and also we start them on corticosteroids. If on decreasing the dose of corticosteroids, the patients were having fever, we restart corticosteroids, and we take then the decision clinically on how to stop the drug or if to continue it for a longer period of time. The dose reductions for dabrafenib would be 150 mg, 100, 75, 50. For tremetinib would be 2, 1.5, 1 and 1 mg continuously. So safety summary, we know that dabrafenib tremetinib has manageable toxicity, and it is similar to what we knew from the melanoma study. Most common issues are pyrexia, GI-related issues, and skin reactions, of which pyrexia forms the major trouble for the physician that is using the drug. And it should be managed in a protocolized manner such that most of our patients are able to take the drug and take the drug for a longer period of time. Thank you very much. Hello.
Yeah, thank you, Dr. Akash Tiwari, sir.
So we move on to our next presentation. I think Dr.
s-
Gautam has joined.
mm,
Dr. Gautam has joined.
No, sir. Dr. Gautam will not join because I think he has messaged that he's busy somewhere. So can we go further for your conclusion?
Yeah, sure. I'm extremely sorry for Dr. Gautam. Maybe he'll take his lecture maybe tomorrow. So just to conclude, it's my sincere thanks to the members of the scientific committee, to the invited speakers and conference organizers and sponsors for their commitment to this conference. We hope that you enjoy the meeting and will already make a note in your diary for tomorrow, that is 6th March 2022, for having again an academic feast at 6 p.m. Thank you. Thank you very much.